Okay, I'm back, and now we're going to start, this lecture is going to be on chapter 66 in your Lippincott book that starts on page 1935. So now, after we've talked about how do you assess your patients, some neuro things to watch for, we're going to talk about how do you manage patients with certain neurodysfunctions. Couple things I want to point out that you do need to know. If I'm going to start here on the glossary, you need to know Cushing's response and Cushing's triad. That becomes very important in patients who have neurotrauma. And the Cushing's triad is this sequence of events based on the heart rate, blood pressure, and respiratory rate, and it's an indication of how well that the brain is functioning. And it's when you see these happening, it's an indication that the intercerebral swelling is getting worse. So we're going to talk more about that. You do need to know decerebrate posturing and decorticate posturing. I'll explain that more later. The Monroe-Kelly hypothesis, and I think I talked about this before, maybe in class or something. And that has everything to do with how much space is in the brain and how they compensate for each other. Intracranial pressure, we'll talk about that. We're going to talk a little bit about headaches because headaches are so common, and seizures. So those are the ones that we're going to talk about. Some of the rest of these, level of consciousness, hopefully you're all pretty familiar with that. So I'll explain a little bit about that and how to assess for that. Okay, so let's get started. The first thing I want to talk about is the space inside your brain. It's made up of three things: brain tissue, blood and blood vessels, and cerebrospinal fluid. And those three components work in concert with each other to maintain a normal intracranial pressure. Normal intracranial pressure should be less than 15 millimeters of mercury. So you've got about 15 millimeters of mercury to play with, and the brain tissue, the vessels, and the cerebrospinal fluid will compensate for each other. So for example, if you've got a little more swelling, like following a concussion or a head trauma, so that the intracranial cells, the cerebral cells themselves are swollen and damaged, then it'll send signals down to like the kidneys to absorb more cerebrospinal fluid or more blood from the blood vessels. So the blood vessels will shrink, there will be less cerebrospinal fluid, which is going to give a little more space for some swelling that might be occurring in the brain. And likewise, if you have a patient who has fluid overload or hypertension and they have too much volume in the blood vessels, then cerebrospinal fluid might get reabsorbed, or reduction in production of cerebrospinal fluid, or the the brain cell, the brain tissues itself will shrink, and in order to maintain this intracranial pressure. The problem for you as a nurse is that when those compensatory mechanisms cannot adequately accommodate, and that intracranial pressure starts going up for a variety of reasons. It could be a bleed, head trauma, a tumor. There's all kinds of things that can happen. Then you have to compensate and start intervening with some nursing interventions to try to help maintain and regulate that intracranial pressure. When the intracranial pressure starts getting elevated for whatever reason, then you can start seeing alterations in level of consciousness. And that can be anything from just sort of lethargic and difficult to arouse all the way to coma. So there's varying degrees of level of consciousness, and it has everything to do with that increased intracranial pressure. In addition to, as you know, fluid electrolyte status, what's the sodium doing? Because your brain loves us, that's sodium between 135 and 145. So there's some other components in there. Well, the rest of that you can read. Under altered level of consciousness and the pathophysiology, you can read through that. Okay, so now in minor head trauma will often result in concussions, which is why so many schools now they'll get a baseline concussion status before the student starts doing any sports. And then in the event of a concussion, the treatment for concussion, because concussion is basically like you've bruised your brain. So when you're out playing some sport and you get hit, let's say you take a football or a ball or whatever, racquetball to your arm, it hurts, it bruises, it swells up, and it's sore. The problem is when it happens in your brain, because your brain is encased in the skull, it doesn't have anywhere to go. So common symptoms following a concussion are sleepiness. Sleepiness is the first indication of intracranial pressure, and alterations in level of consciousness is this difficulty to arouse, and that means that there's more swelling on the brain. So that's why we watch for people that are sleepy following head trauma and concussions. Treatment of choice is to reduce the metabolism in the brain, reduce the activity in the brain. So that's why somebody who's sustained a concussion, they don't return to activity right away, and they should be resting at least for 1 to 2 weeks, depending on the severity of the concussion. It could be as long as 6 to 8 weeks in a dark room. Keep them quiet because you're trying to reduce the activity in that brain. So those are easy first aid for minor concussions. Now, when that head trauma gets significant and that the intracranial pressure, which is on a pretty steep curve, so you've got like 0 to 15 with that increased intracranial pressure, and your brain can do a pretty good job accommodating that. When you hit that 15 millimeters of mercury mark, that curve goes up pretty substantially because now you don't have hardly any room to compensate. And when that starts getting higher, above 15, now we're talking 20, 25, 30 millimeters of mercury, that is a lot of pressure in that brain. And you're going to start seeing some other manifestations of that. Your patient is probably going to be unconscious, and they can start doing some of these things that you see on page 1938, where they do this very unusual posturing, and they will start having some very unusual neuroreflex responses. And the one is decorticate posturing and decerebrate posturing, and they're both very unusual posturing, and it means the brain is very damaged. So, and this is how you can remember it. There's a figure on the top of page 1938, but this is how you remember it. This is how I remember it. Decorticate is you're coming into the core, and this is your core. So decorticate comes into the core, and their hands roll up like this, and they come in and they get really tight, and their legs get extended out, like they're like a diver or something like that. And then in decerebrate posturing, the arms roll out, but they come down to the side. Both of those are pretty ominous signs. That means that there's a lot of pressure, and it's sitting right back on that brainstem. There are some other manifestations, and you can tell how significant your patient's trauma to the brain is. And by trauma, I don't just mean getting hit in the head. This can also occur in your patients who have brain tumors that are inoperable. That brain tumor continues to grow. Hydrocephalus, fluid on the brain, if that comes on pretty quickly, these things can, aneurysms that rupture in the brain can cause this. Any excessive amount of pressure in the brain can cause these ominous signs. Also look at the table 66.1. If you should be able to talk to a normal functioning person and say, "Hi, Mr. Smith, can you open your eyes? Can you tell me where you are? Can you move all your extremities? Can you show me 2 fingers?" And a healthy, undamaged brain will be able to process, what are you saying to me, and can I follow those commands? In a brain that's getting damaged and that intracranial pressure is getting up really high, you'll start seeing other things, like the pupils will start dilating. And that is, remember when we talked in the last chapter on assessment, when the pressure gets so high in the back of the brain, that's coming right down on that brainstem, and right on top of that brainstem is where the ocular nerves, cranial nerve number 3, sits right on top of that brainstem. So as the brain starts to, it's called herniate, meaning the swelling is getting so bad, and the blood vessels and the cerebrospinal fluid have accommodated as much as they possibly can. The only other place for that brain to go is down on top of the brainstem, because there's that's the only opening in the skull, is where that brainstem comes up into the skull in the back of your head. And so when that brain starts coming down through the tentorium right on top of that brainstem, it's called herniating. It's herniating the brain. And one of the first signs you'll see that that's occurring is the pupils will blow. Sometimes the brain will just start herniating on one side and only one pupil will blow, but sometimes it comes right down on both, and then you know that that brain has herniated. That's a really, really ominous sign. Most of the time you can't recover your patient from that. You still try with some other things like, we'll talk about more of it, but the osmotic diuretics, because that will suck fluid out of those brain cells and shrink those brain cells and hopefully give you a little bit more room. Or if it's a fluid thing, you can put a ventriculostomy into the ventricles and drain fluid off to reduce the cerebrospinal fluid that's in the brain. So you can do some other things to try to pull that fluid off, but once you get to that level where you're seeing some pupillary responses, that's a pretty ominous sign. Neck rigidity is very important when you're doing your neuroassessment, because your patients who have meningitis, viral and bacterial meningitis, will often complain of a stiff neck. So if you're worried about meningitis, if you pull your patient's head forward like this and they're complaining of what's called nuchal rigidity, that's just a fancy word for neck, their neck is stiff, that's an indication that your patient might have a meningitis going on, which is going to cause inflammation in the cerebrospinal area and the meninges. The other one is, I wanted to point out the Babinski reflex. See down here at the bottom of this table 66.1 where it says a pathological reflex. If you take your toe or your finger and go like that, in a Babinski reflex, the toes will curl out like that, and that's an abnormal response, meaning that there's probably an issue, that your patient is not doing very well. Okay. The next couple pages really talk about how do you take care of a patient who is unconscious or who is in a semi-comatose state. And there's a lot of patients who have had debilitating strokes, head injuries, some patients who were born with significant birth trauma or birth defects. They can be in an altered mental state, at which time becomes difficult nursing care, because now you have to manage all those body systems for the patient. You've got to make sure that you're turning them really well so they're not getting skin breakdown. You have to make sure that their nutrition is good, but because they're not up walking around, their peristalsis is not going to be as good as somebody who is moving, because peristalsis in the GI tract improves with movement, so these people aren't moving, so they're prone to constipation. So you have to make sure they're on stool softeners, increase their fiber in their diet. They may be on PEG tubes or G tubes or NG tubes to get nutrition in, depending on if they're able to eat or not. Elimination is a problem. They may need ostomies. They might need a urostomy for urine control, colostomies for bowel control. There's a plethora of things that you have to manage in your patient who is in a semi-comatose state. Many of these patients end up being in rehabilitative facilities, but some of them go home. So now if they go home, who's going to manage that person at home? And it's it's really difficult on family members, especially if it's following a stroke or trauma, because now not only do they have all the physical things, they have the emotional component of the person that is now in the semi-vegetative state or even an altered state, not necessarily vegetative. They have a different personality. They've got, they can't function as well. That is really hard on a family system. So there's a lot of social support that goes into taking care of patients who have altered mental states, especially if it's a sudden onset. Okay, so now we wanted to focus a little bit more. We talked about increased intracranial pressure. Now I'm over on page 1942 and 43. And this is where the Monroe-Kelly hypothesis comes in that I was telling you about. In the Monroe-Kelly hypothesis basically says you've got these three components in your brain, and they will each one will compensate and alter for the other ones in order to maintain equilibrium within the intracranial cavity. So that's basically what the Monroe-Kelly doctrine says. The blood flow to the brain, with every heartbeat, the brain gets about 12 to 20% of the cardiac output. The brain is one of the first organs to protect itself. So in the event of a trauma or something, the brain and the heart are going to get the oxygen. The skin, the GI tract, they're the first to go. So the brain is really good about protecting itself. The other thing that you need to know about the brain is there is a blood-brain barrier. So a lot of the medications that we give our patient don't cross the blood-brain barrier. So some things, if you some drugs you want to get to the brain, you better make sure that it has the capacity to cross over that blood-brain barrier, because the brain will protect itself from a lot of things that it doesn't want. It's really good about that. The other thing I wanted to finish talking about is this Cushing's response. When the pressure in that brain starts getting too high, the heart rate, the blood pressure, and the respirations will start changing. And in the event that the pressure is getting too high, one of the ominous signs is when this Cushing's triad starts. And what happens in Cushing's triad is the heart rate starts dropping, the blood pressure starts going up, and the patient starts breathing slower. So heart rate and respirations will start going down, blood pressure starts going up. That is an ominous sign. That is an indication that your patient is probably getting really close to herniating, so you better start intervening really quickly. Another thing to keep in mind is your patient's carbon dioxide status. Carbon dioxide molecule is bigger than an oxygen molecule, so if you let your patient's CO2 get too high, that is going to take up more space in the blood vessels than if they have lower carbon dioxide and higher oxygen levels. So you want to make sure that your patient is not retaining CO2, that they're getting adequate oxygen. You want to make sure that they're oxygenating well. Keep a close eye on their ABGs, their arterial blood gases, to find out what is their carbon dioxide and what's their oxygen level doing, because you want to be very careful to not let that carbon dioxide get too high. Another thing that you can do in your patients who have increased intracranial pressure is this is when hypertonic solutions are good, because you want to shrink the cells. So you're going to want to give something that's at minimum isotonic and maybe hypertonic, because you deliberately want to dehydrate your patient, because you want that brain cells to shrink. Now it's going to be hard on the kidneys, it's hard on the skin, but we can deal with that later as soon as we get that brain back under control. The other thing that you do when you're giving a patient who has head trauma fluids is you don't give it at a fast rate. You would never give somebody who has increased intracranial swelling, you would not give them fluids at, to 150, 200 cc's an hour, because their brain can't accommodate that. So you would maybe hypertonic fluid at 20, 30 cc's an hour might be all they need. Because you don't want to fluid overload them. You do want them dehydrated. You can give osmotic diuretics like mannitol. Mannitol is a great osmotic diuretic, and that will suck fluid from the intracellular spaces into the intravascular spaces, and the kidneys will get rid of it. And again, it's hard. It will lead to like a hypertonic state, but you want that because you want your cells dehydrated, because you want to accommodate as much space as you can. The other things that you're going to do in your patient who has increased intracranial pressure is make sure that you're maintaining head alignment. You don't want the head to flop over here like one way or the other, because now you need to maintain jugular drainage. So you don't, when you put your head like this, when your patient's head is like cocked over, then it restricts the jugular vein, and then all of a sudden all the blood that's trying to drain out of the veins in the cranium are getting sort of backed up. So you want to minimize that. So you got to keep your patient's head in nice alignment. You want to keep the head of the bed up at a 30-degree angle, if possible. Now if the person was in a trauma and they also have a spinal cord injury and you can't do that, then you can't do that. Sometimes you can kind of put them up in slight Trendelenburg, so that they're still in alignment like that. And dark, quiet room, minimal activity. You don't want a lot of loud noises going on. You want to minimize visitors. maybe allow for 1 or 2 visitors, because sometimes that's calming to have family members in there, but this is not the time where we're going to have a party and have the whole family in there. So anything to minimize the work activity of the brain. Make sure that you're taking care of their pain, because pain will increase the activity in the brain. And sometimes you can put a patient in what's called a drug-induced coma, and that will reduce the workload of the brain. You do have to be careful. This is when you want your patient on a ventilator, because this is what happened to Michael Jackson. Is like propanol is one of the drugs that reduces the stimulation in the brain. It's a very powerful it's like a paralytic agent, but if you don't have somebody on a ventilator, you'll shut off they won't breathe, which is what happened to Michael Jackson. But if your patient's on a ventilator and you can, make sure that they're getting good oxygen, then you can give them some of these drugs that will put them into a coma. Now, when they're in a coma, keep in mind, you can't do like your Glasgow coma scale. You can't say, Mr. Smith, can you wake up? Can you move your fingers? Because they can't. So sometimes they give them what's called a drug holiday, and you will lift the drugs, and oftentimes these are on drips, like just a constant drip that you put somebody on to put them in a drug-induced coma. You will lift that or stop that for a while, and then reevaluate how your patient's neurostatus is, see how they're doing. And if they're better, great, then we can wean those drugs off. And if not, then we put them back on, atracurium or, whatever neurolytic agent that they're on that's putting them in a drug-induced coma. So those are some things to keep in mind when your patient has increased intracranial pressure for whatever reason. And then we're going to talk the rest of this time about what could be some of those different reasons. Okay, you don't need to... So, okay, now I want to move over to some of the different ways that we know what somebody's increased intracranial pressure is, because you can't just look at somebody and tell, oh, his intracranial pressure is 10 or, whatever. You have to have a monitor in. So if you will look at page 1945 and figure 66.3, it shows you some of the different ways that we can monitor and manipulate some things in the brain. If your patient has a monitor in the brain, they will be in the ICU. You don't walk around outside with a monitor or drain in your head, because your patient's going to be at very high risk for infection. However, like for example, you can put a ventriculostomy right into the ventricle, and this would be none of the... Oh yeah, A. Letter A is the intraventricular catheter, where they put a catheter in, and the surgeons have to do this. They bore a hole, like a little drill. They'll drill through the skull, and then they put a tube into the ventricular space, and then it will drain out. Some of them are just hooked up to monitor. If you just, like if your patient doesn't have a lot of excessive fluid, so like if it's not if they're not hydrocephalic, where they have too much fluid in the ventricles, or if they didn't rupture into one of the ventricles where they have a lot of bleeding in one of the ventricles and you need to get rid of some of that fluid, you can hook that ventriculostomy up to a bag. And you have to be very, very careful, because usually the bag, the drainage bag is leveled at the tragus of the ear, because the ventricles are right behind the tragus of the ear. The tragus is that little tag, the little flappy part that sticks out there. Your ventricle is almost directly right behind that. So typically the drainage bag comes out and it's set. You'll get an order for it. It will say, drain at 15 millimeters of mercury. So then if your patient's, the pressure in their brain gets up to 17, 18, 19 millimeters of mercury, based on gravity, that will come out and drain into the bag. But if the bag drops based on gravity, you can suck all the cerebral spinal fluid out of that ventricle and cause a significant problem. So you do have to be careful if you have your ventriculostomy hooked up to drain. Oftentimes, it's not hooked up to drain. You just want to see what their pressure is doing. So then you can do other things like a subarachnoid screw, a subdural bolt. You just put a transducer like a monitor into the head, and same way the surgeon will burr a hole through the skull, and then they insert like a like a transducer, a fiber optic thing that will transmit to the monitor what the patient's pressure is, so you can adjust their fluid status. You can adjust their how much mannitol they're getting, things like that, because that's how you can tell if somebody what their ICP is. Okay, so those are some of the different monitoring devices in somebody's head. There's some more pictures of it on figure 66.5 on the next page. And then also read through, and I also kind of mentioned most of this, decreasing cerebral edema. Usually your patients who have some kind of increased intracranial pressure may also be on steroids. Steroids are a great anti-inflammatory. The thing with steroids is you do have to taper it off. Remember, you don't, like if you start somebody on steroids, you don't just stop it abruptly. You have to do a steroid taper. If they're on it for long periods of time, you have to worry about adrenal insufficiency, because you'll remember that your adrenal glands, which sit on top of your kidneys, excrete cortisol, which is a steroid. So if you're giving somebody steroids, then the brain thinks, oh, we're getting steroids, and then the adrenal glands, sometimes this is chronic steroid use, those adrenal glands will quit working, and then when you take the steroids off, the adrenal glands don't kick back in with the corticosteroids, and you can have adrenal insufficiency because of long-term steroid use. So you have to be a little bit careful about that. And then we can give some other medications that will maintain cerebral perfusion. This becomes a problem like in your patients who have shock, where they have massive vasodilation, and you want to make sure that the brain is getting perfused. You might have to put your patient on a medication that is a potent, what am I trying to say, like an inotropic drug that is going to increase cerebral perfusion pressure. Your cerebral perfusion pressure is easy to figure out. You just take your mean arterial pressure, and you know how to figure that out with your systolic blood pressure plus 2 times diastolic divided by 3 minus your intracranial pressure will give you your cerebral perfusion pressure. Fever is another thing that you need to control. If your patient has a fever, it's going to increase the metabolic demand and increase the activity in the brain, so you want to control fever. Another thing that some hospitals are doing now is induced hypothermia, because if a patient is really cold, all of their metabolism slows down, all of their body functioning slows way down, the heart rate slows down, everything kind of slows down. You know this when you go outside, and this concept is the same thing like that the animals do when they hibernate. They get just really cold and everything slows way down. And so there has been some work now to try this induced hypothermia. The jury is out about whether or not this is really beneficial in helping long-term neuro problems, like with following trauma and high levels of increased intracranial pressure. But some hospitals are still trying it, and there is more research and work being done about whether or not hypothermia works. The trick here is also you've got to prevent shivering, because when you shiver like that, that's the body's way to increase heat. So you want to prevent the shivering, because shivering takes a lot of brain work. So you also have to give medications that prevent shivering if you're in a situation that is doing induced hypothermia. Okay, there's a good table on page 1948 about some what causes increased intracranial pressure, what are some interventions that you can do about it, and why. So you might want to look that over. This nursing flow sheet they have in here on page 1948, it's good. It incorporates the Glasgow Coma Scale. The Glasgow Coma Scale is kind of these first like 3 or 4, about the first 3 or 4, like the Glasgow Coma Scale, a variation of it, and it doesn't include the pupillary response. When you're checking somebody's neurostatus, are they oriented to person, time, and place? Do they wake up to touch, or do you have to do like like, hi, Mr. Smith, I'm going to be your nurse today? Or is it more like I have to do noxious stimuli? By noxious stimuli, I mean compression of the nail bed here, because that hurts. And if you compress the nail bed and somebody pulls back, that's a normal response. If they don't pull back, or they do one of those weird posturing things I told you about, that's an abnormal response, and then you document it as such, all the way down to there's no response at all. And that's an ominous sign somebody's probably close to brain death. But keep in mind, you have to make sure somebody is not on medications that is also going to alter their response. And then you want to check their pupils. Mr. Smith, can you open your eyes for me? I'm going to shine a light in your eyes. Because of that consensual reflex, if you shine a light in one eye, it should also, the pupil in the other eye should also react similarly. But if not, it doesn't always. If there's no problem, you document it as such, and that comes out to the that's your Glasgow Coma scale basically. All right, I talked about preventing infection is really important when somebody has a tube in their brain, as you know, because you know how anytime you have introduced a foreign object into the patient, that's an avenue for bacteria and infection to occur. We hear it all the time with CAUTIs, catheter-induced urinary tract infections. What's the other one? The ventilator-induced pneumonia, VAPS. And so, like, phlebitis can occur when you have IVs in, and the same thing can occur when you have a ventriculostomy in the brain. Is you got to be really, really careful, because if bacteria gets into that site, you can cause meningitis. And in an already traumatized brain, that's not good. So you need to be careful. Sterile technique on that dressing, aseptic technique when you're in the room. So now let's say that your patient has something going on in their brain that is causing increased intracranial pressure that needs to be operated on. This could be an abscess in the brain. It could be a tumor. And any tumor that's growing in the brain has to be operated on. Let me take that back. Any tumor that's growing in the brain that's causing symptoms and has the ability to be operated on should be. Now, there are some brain tumors that don't do very well with surgery, because instead of, like, for example, a meningioma is a tumor that's arising up out of the meninges. Those are not cancerous. It is a benign tumor. The problem is you can't have a growing tumor in the brain because there's nowhere for it to go. So if you have a fatty tumor or something else anywhere else in your body, it can continue to, I don't mean anywhere else, like, you know, like your abdomen or your arm or something like that. You can have something growing and it's not going to affect anything. It might look unsightly. You might have this big lump there, but it doesn't necessarily have to be removed because it's not going to affect anything. So if a meningioma is growing in the brain, it needs to be operated on, because it will still kill a person even though it's not malignant. There are some brain cancers, such as glioblastomas, astrocytomas, that are more spider-like. And so when those start growing, they grow like this. And those are very, very difficult to treat, because you can't get all that with surgery. You can't go in and down every single one of those little limbs. You can't get to that. Sometimes they will go in and do what's called debulking, where they will, like, let's say this is the heart of the tumor and the tumor kind of spreads like that. They can go in and debulk, meaning they'll take out a big section of tumor, and that might buy a person a little bit of time, and then they can maybe try some radiation or chemotherapy in an attempt to try to cure the patient. Those patients don't do as well as like a meningioma, where they can go in. You have to have neurosurgery and open it up, or an acoustic neuroma is a tumor that's growing around the acoustic nerve. You have to go in and fix those, and most of the time they don't grow back. Sometimes they grow back and you have to go back in and do surgery, but they don't need to be followed up with radiation or chemotherapy because they're not malignant. So if you look down here at the bottom, those are the different kinds of craniotomies. They shave the head. They will make a flap in the skull. It's either supratentorial, infratentorial. Sometimes it's, ear to ear if they've got to get to the frontal lobes. Sometimes it's transphenoidal. The transphenoidal, they don't have to crack the skull. They go in through the nose. That's if somebody has a pituitary tumor on their pituitary gland. They can often go right up through the nares and get to the pituitary that way. When they do surgery, they shave the head, they make an incision in the skin, and then they pull the skin back to reveal the skull. And then what they do is they often will make burr holes. Turn the page and look at page 1954. See where they have burr holes there? Oftentimes what they'll do is they'll make burr holes and then they connect the dots, and then they'll take that whole section of skull out and they'll set it aside in the operating room, and then that allows the neurosurgeon to get to the brain, and they can operate on that area of the brain. And then they put the skull back on top, put the skin back on and suture it up. And that's how they do a lot of the neurosurgeries. So just be aware, if you hear the word supratentorial, that's above the tentorium. Infratentorial is behind the tentorium. And transphenoidal. The things you're going to watch for after your patient who has had neurosurgery for any kind of problem: seizures. You want to prevent seizures. That's a risk factor. Pain is a problem. They have headaches. You want to reduce cerebral edema. They're often in the ICU, so they can be monitored a little bit more closely. Take care of the family, because the family will be nervous. Everybody, if your loved one's going in for brain surgery, that's a scary thing. So make sure that you're attending to the family's needs, answering their questions, telling them what to expect when they get back. Because their hair will be shaved and they'll have a big bandage on their head. And oftentimes that's scary. Even if it's just a no big deal meningioma, brain surgery for anybody is a big deal. It's just that the life expectancy for somebody with a meningioma versus, a glioblastoma is quite a bit different. Okay, now once your patient is starting to recover from either neurosurgery or seizure, increased intracranial pressure, strokes, you need to protect the airway, because the gag reflex is innervated by nerves, and so you need to make sure that person can swallow. Oftentimes speech therapy or occupational therapy, depends on who does this in your hospital, will come up and assess if a patient's gag reflex is okay, and you want to make sure they're doing this before you're starting to feed them, because you don't want them to aspirate. Sometimes what they'll do is give a patient like some grape Kool-Aid and see if they can drink some fluid that's colored. Then if the patient starts coughing, if you all of a sudden if you gave them grape Kool-Aid and now you have purple colored sputum, you have a pretty good idea that Kool-Aid went down the wrong pipe. It went down to the trachea instead of the esophagus. So that's something that you need to watch for before you start feeding your patients following craniotomy. The other thing is that patients who have head trauma and craniotomies, neurosurgery, another way to reduce the pressure in the brain is no straining. You don't want them bearing down, like when a patient has a bowel movement, anybody has a bowel movement, or you bear down, like if you get really mad and go like that, it puts pressure on your vagus nerve. Your vagus nerve runs right down your core, and the vagus nerve, it increases your intracranial pressure. It slows everything down, but it increases the intracranial pressure, so you do not want your patient straining. You don't want them sneezing, you don't want them coughing, you don't want them straining. So you're making sure that they're suctioned, that they are dehydrated. If they you don't have them blowing their nose. Do not have them blow their nose. So if they're congested, they're just wiping their nose. You give them decongestants, but you have to be careful, because certain decongestants will raise the blood pressure. And you give them stool softeners and fiber, so that it reduces their constipation, so they don't want to strain when they're having a bowel movement. So those are some other things you have to watch for in your patients who have increased intracranial pressure. The transphenoidal approach, just kind of skim through that. That's the one for pituitary tumors. That one has some fluid issues with it afterwards. Those patients because if you'll recall, that releases antidiuretic hormone, so you can have syndrome of inappropriate antidiuretic hormone. You have huge fluid losses afterwards, but that's not. They can give DDAVP and fix that pretty easily. Okay, now the seizures. Skim through the seizures. The thing that you do need to know about is there's a lot of different kind of seizures that a patient can have. And lots of times they don't know why a person has a seizure. Sometimes a patient can just have 1 or 2 seizures their whole life. Some children are born with seizures, and then they actually have a disorder called epilepsy, and there's not a great cure for it. We do have a lot of good drugs that we can put patients on, and sometimes they can go in and they can find a certain area of the brain that's like hypersensitivity, electrical activity. Sometimes they can take that piece of the brain out. Some of those things work. Certain drugs can cause seizures. High fevers can cause seizures. So there's a lot of different things, like neurosurgery can cause seizures. And so you need to be aware of what a seizure is and what to do about it as a nurse. If it's a one-time thing, your most important thing that you can do as a nurse is get your patient to safety. Some patients who have long-standing chronic seizures, they will get something called an aura, where they know that it's coming. They can kind of sense that it's coming. It could be a light, a certain light. They can get a certain smell. It can be auditory. Any of the 5 senses can get an aura. And they can hear a ringing or something like that. If the patient says, "Oh, I think I have a seizure coming on," if you're near them, get them to safety. Help them to get to the floor. If they're in bed, turn them on their side. And there's really, when they're starting to have a seizure, there's nothing that you can do other than stay with them, get them on their side, because if they aspirate, you want the vomitus to go out and not into their lungs. And then record, when does it start, what does it look like, when did it end, what happened right before, and keep the patient safe. If your patient has a long-standing seizure disorder, and it could either be major, like tonic-clonic, or it could be small, petite malls, or just little seizures that are like some of them have just like lip smacking, or they just sort of stare off into space and then they can't quite remember where they were. Those could be seizure activities. There's a lot of medications that we put patients on for them. Most of those medications cause the patient to be drowsy, because the whole point of those medications is to slow down the electrical activity of the brain. So patients who are on these medications are often groggy and drowsy. A lot of those medications we need to monitor for levels, especially Dilantin. Dilantin is a great anti-seizure drug, but you need to make sure that they're not getting toxic. So you have to watch the levels, because you don't want it to get too high or too low. And most of them have other side effects. Like Dilantin can cause a lot of gum hypertrophy. So if you've seen somebody who has a history of epilepsy and they've been on Dilantin for a long time, they may have gum hyperplasia. There's a good, when you look down there at, well, basically pages 1960 and 1961 talk about what do you do during a seizure, after a seizure. So look through some of those things. The one that you really is most, they're all concerning from a safety standpoint. If somebody's had a seizure and it's their first time, they can't drive for a period of 6 months, because if they were to operate a heavy machinery, and if you see that on NCLEX, operating heavy machinery, a car counts as heavy machinery. We're not just talking, a forklift somewhere. They should not be driving in the event that they have another seizure. And there's certain things that trigger seizures. Repetition like this. So people who are on computers a lot, like, have you ever seen a computer screen on the TV and you see those lines going through like that? When you're sitting in front of your computer, you can't see that, but your brain picks up on it. And so sometimes people who have seizure disorders can't sit in front of their computer for too long, or if they're driving along the highway and the sun is coming down at a certain angle and they keep hitting trees, so it's like sunny, dark, sunny, dark, sunny, dark, that can cause seizures. So you have to be careful that somebody who has a seizure disorder is not driving, at least for a period of 6 months, until you know that they're not going to have another seizure. The one that you really need to worry about as a nurse is status epilepticus. Status epilepticus is a medical emergency where your patient goes into a tonic-clonic seizure and it's not stopping. The problem is the patient just gets completely exhausted and they can die if you don't intervene. So if a patient comes into the ER, they're in status epilepticus, meaning they're having major tonic-clonic seizures that is lasting for a significant amount of time. We're talking several minutes. Usually a seizure just lasts 30 seconds, maybe 2 to 3 minutes, but when this starts lasting 5, 10, 15, 20 minutes and it's not going away, now you start getting pretty nervous, and you've got to get the patient to the hospital. Hopefully they have an IV. It's extremely difficult to start an IV in somebody who's got tonic-clonic seizures, and then get them on some IV anti-seizure medications, phenobarbital, things like that, to get those seizures under control. Okay, so on table 66.4, you can see some of the different seizure medications there, and some of the side effects of that. So kind of familiarize yourself with the seizures because it's a fairly common disorder, and some of the medications. Okay, now let's talk a little bit about the headaches. There's a couple different kinds of headaches. The most common being like a migraine headache. A lot of people have migraine headaches. And tension headaches and cluster headaches. Those are the three that are kind of like the major headaches that people will have. The migraine, the tension headaches are the easiest one. It's caused by tension. And oftentimes in the headaches, they think that it occurs because the vessels in the brain are starting to spasm. So, and then the migraine headaches, same thing. It's increased pressure in the brain and spasming in the vessels. There's all kinds of medications out that are really good for headaches. Caffeine is great. So if you have a patient who has tension headaches, you know, the Excedrin headache and Excedrin headache medicine, it's got anti-inflammatories like acetaminophen and stuff like that in it, and caffeine. That helps a lot. Some of the headaches, like the cluster headaches, need oxygen to relieve the pain, and a lot of them, like migraines, migraines have a lot of oftentimes have an aura. Like the patients who suffer from migraine headaches know that they're going to get these headaches, and sometimes they just have to lay down in a dark, quiet room, and then it'll pass after sometimes 6 to 8 hours. Sometimes it takes a while. There are some new medications now, and you do the same things that you would do for a patient who has increased intracranial pressure. A quiet room, treat the pain, and sometimes the pain is so severe that now instead of just the Tylenol, ibuprofens, now you might have to move into some of the narcotics to try to get the pain under control. So, and then the tension, you know, you guys probably all have tension headaches, like when your stress levels are high, when you're exhausted, when you've been reading too much, studying too much, you get a headache. So you want those patients to stay hydrated, and then Tylenol Motrin is usually the treatment of choice for headaches, but sometimes they can be pretty debilitating. Chart 66.7 talks a little bit about migraine headaches, how to handle and what to do, what to teach your patient about it. So, okay, that's a lot for this chapter. So we're going to end here, and then in the next chapter we're going to talk about the vascular problem, the very specific vascular problems that can occur, basically your aneurysms and strokes. Okay, that's it. See ya.